So I'm going to be doing a head to toe assessment. I'm doing hand hygiene and for the baby's protection as well as my own. And I'm going to put on some gloves. I'm explaining to the mom, Sophia, we're going to be doing a head to toe assessment on your baby today, just to kind of look and make sure that everything seems normal with the baby. If you have any questions, feel free to ask them.
Okay, thank you.
So initially, when we start, obviously you will not have the baby under a warmer, but you'll have the baby in the isolette in the room. So you want to prevent hypothermia by keeping the baby covered when possible. I'm going to begin by assessing the baby's band and checking the number. And I'm going to have Sophia read me her number and we'll see that they're the same.
My number is 178241.
Yep, 178241. Perfect. So we know that this is her baby. Whenever you take the baby in and out of the room, you want to make sure you're checking the band so that you're bringing the right baby back to mom. Okay, so we check the band. So while the baby is relatively quiet, I'm going to listen to the heart tones as well as count respirations and check temperature. So you want to listen at the apical pulse for 1 minute. Sometimes if you have a hard time assessing the heart rate, if you tap your finger, it can help you assess the heart rate. Takes a little bit of practice because babies' hearts beat very fast. Baby has a normal heart rate of 136. And now I'm going to listen to the lung sounds. And when I flip the baby over, I'll listen to the rear lung sounds at that time. So, and I'm going to check the baby's temperature before I begin my actual head to toe assessment. I have noticed that the mom's bonding well with the baby. She's breastfeeding. Baby spends most of the day with mom, skin to skin. There's no social services involved with this couplet. It's a baby boy. He was 39 weeks and 2 days at birth. Mom had no complications. Like I said, they're breastfeeding. And there was no risk factors noted. So I'm going to get the baby's temperature. So when you get an infant's temperature, you're going to bring it to the side and then you're going to bring the arm straight down and hold it. It doesn't hurt them, but they usually don't like being held. And you're going to hold it down. Obviously, a baby's arm will go flush against it, and then you hold it there until it beeps. Baby's temperature is normal, 98.2. Now we have gotten the vital signs on the baby, so we're going to start. I start from the top to the bottom. For purposes of this assessment, I'm going to go ahead and open up the blanket so you can see, but during your actual assessment, you want to kind of keep the baby relatively covered if the room is chilly. The first thing I'm going to do is I'm going to check the baby's myotone to make sure. We want the baby to be nice and flexed. As you can tell, the legs are flexed and the arms are flexed. He's moving all of his extremities. He's not rigid. He's not limp or flaccid. He's not hypotonic or hypertonic, and he's not jittery.
What is that white stuff on the skin?
That's what we call vernix. When babies are in the womb, they're in a 9-month-long water bath, so they need something to protect their skin. So this is kind of like super lotion. I call it super lotion. It's like vernix all over the body to help protect the baby during that long 9-month bath. And then as the baby is born, or as the baby ages, when they're born premature, they have more vernix, and when they're term, they have less. You don't really need to wipe it off. Just kind of let it absorb into the skin. It's good for their skin. And so that's what it is. It's very normal.
Oh, good.
So we're going to go ahead and do the sucking reflex. So I'm going to insert my glove finger, and I'm going to check that the baby sucks, and the baby is sucking. At the same time, I'm going to check the baby's palate for cleft palate. Baby's upper palate and lower palate are both intact. If you touch the baby's cheek, it should turn towards your finger. That's what we call the rooting reflex. It's kind of like a little bird. That's an indication that the baby's hungry. Sometimes when moms don't know when to feed their babies, you let them know when they kind of turn their head and they are doing what we call rooting. That means that they're hungry. Then we're going to check the palmar reflex, where you put your finger and the baby should grasp your finger. And that's the baby's grasping my finger. That's the palmar. And then with the Moro reflex, you're going to gently lift the baby up and then let him go. And the baby should do what's called a startle reflex, where they go, woo, that's the Moro. Okay.
Nurse Shauna, why do we have to do reflexes?
So all babies are born with these instinctual reflexes, and if they're not present, that can be an indication that maybe something neurologically is altered, and so that's why we're checking the reflexes. These reflexes are primitive when they're born, and as they get older and they age, they slowly start to disappear. So if a 1-year-old child still has a Moro reflex or a stepping reflex, that could be an indication of a neurological deficit. Baby's crying, you can notice that he has a nice lusty cry. He's not, it's not weak, it's not hoarse, it's just a nice lusty cry. So we're gonna do the plantar reflex, where you put your finger right here and the toes should go ahead and grasp your finger. And then at the same time, you can do your Babinski, which is where you kind of draw up like this, and the toes should splay out. Those are the two other reflexes. And then we also have the stepping reflexes. I'm going to show you that on this baby. You're not going to obviously, but if you turn the baby like this and you put them down like this, they actually step like they're walking. It's just a natural reflex. So we notice that their cry is lusty, they have all their reflexes, their monotone is great. So now we're going to start at the head. You're going to fill the head you're going to fill our sutures and our fontanelles. The anterior fontanelle is soft, it's not bulging. The sutures here are separated, they're not overriding. This baby was born via C-section, so sometimes when they're born via C-section, they don't have all that molding from coming down through the vaginal vault. His anterior fontanelle is also soft and not bulging, and like I said, the sutures are separated, but not extensively. This is very normal. Shape is round. I noticed that the eyes are in line with the ear. Eyes are in line with the ear. The baby's eyes are open, sclera is clear. I don't notice any drainage. If I'm looking at the ears, I'm not noticing any drainage. This baby does have a little ear tag, which is a little piece of skin. Something you want to note in your assessment, that they're on the right ear. There is an ear tag. Notify the pediatrician that we have an ear tag. This ear, no drainage, everything seems normal. Take my pen light, I'm looking up. The nose seems patent. I don't see any obstruction. If you occlude one nostril, breathing out of the other, same thing. We already checked the palate, and we noticed that the mucous membranes are pink and moist. And so that is what we do for our head.
Nurse Shauna,
Yes.
do we have to be careful with the soft spots?
Yes, you don't want to push on those fontanelles. You want to kind of just very gently palpate them. Well, we don't want to push in because the baby's brain's right there. But you would be able to see if the baby had like pulsating, bulging fontanelles. You can visually see it typically, unless the baby has a lot of hair, you can see it pulsating. So we already did this baby's respirations, but I also want to look at the work of breathing. Is the baby breathing normally? When I listened, was the lungs clear? They were clear. There was no moistness. His rate is normal. It's quiet, regular. His lungs are expanding symmetrically. I already checked the mucous membranes. I'm going to look at the baby's nail beds at this time. They're all pink. I do notice a little bit of acrocyanosis What that is when the hands and the feet are a little bit blue. That's very normal. Baby's body is shunting the majority of the blood flow to the main torso and heart and lungs and brain.
So that's okay if his hands and feet are
Blue, yes. But we don't want him to be blue around the mouth. That's oral cyanosis. And we don't want him to be blue in his chest area. The only where we're acceptable is the hands and the feet. Okay, so this is what it looks like when a baby is having respiratory distress. So the first thing you'll notice is the sound that the baby's making. So a lot of times parents will say, oh, my baby's singing. Well, that's not what the baby's doing. That means the baby's having a difficult time breathing, and that's what we call grunting. The baby also is having, if you look at the chest, you can see the accessory muscles in the chest wall working harder. This is what we call retractions. That's another sign of respiratory distress. We talked in the earlier video about the normal acrocyanosis, which you can see here. The baby's hands are blue and the feet are blue. That's not worrisome. That's normal. But if you look, this baby has oral cyanosis or central cyanosis. That's another indication that the baby's not getting enough oxygen. Another thing is the baby can have what we call nasal flaring. And that's where the nostrils will be flaring out. I don't know if you've ever run a race and your nostrils are really flaring so that you're working, you'll notice that on here. And it's just exactly like it sounds. It's just flaring. So what you would want to do immediately with this baby is we would want to get a pulse ox on because we want to see what is this baby's saturation. What is the baby satting at? We want it to be at least above 95%. And you want to get a preductal pulse, which is on the right hand. And then obviously you're going to call if you have a NICU or another if you have a pediatrician to come assess the baby and see what is causing the respiratory distress. Now we're going to go on to the cardiovascular. Again, we went ahead initially in our beginning of our assessment and listened to his heart rate, which was normal at 136. I did not hear any murmur. If you hear a murmur, it kind of sounds almost like a whooshing, like whoosh, whoosh, because it's where sometimes when that foramen ovale does not close right away, they can have a little murmur. Typically, you would definitely hear it if they had one. If you ever have an availability on the floor to hear a murmur, if like one of your fellow students has a baby with a murmur, go in there and listen to it. It's kind of cool. We're also going to palpate pulses. So we're going to palpate the brachial pulses. You don't want to ever palpate the carotid pulses on a baby, just the brachial and then the femoral pulses, which are, ooh, he has a nice poopy diaper, which are right here to make sure that they're equal. And you always want to palpate your pulses at the same time to compare that each side is equal to the other.
Why is the poop all dark like that? What's that called?
That's called meconium. That is their very first stool. They actually make that stool while they're in utero. And so they'll pass that. It's kind of black and tarry and sticky and very hard to clean, but it's normal. So capillary refill, I usually do that on the baby's chest, kind of go just like you would with an adult. You're just kind of just checking to make sure that he has an appropriate capillary refill, which he does. Now we're going to go on to the abdomen, the gastrointestinal. We're going to check his tummy, make sure that it's nice and round and soft. You can palpate, no distension, it's not hard. And then you're going to auscultate his bowel sounds, making sure they're active, which they are. And we could tell that he's moving stuff because his diaper's got meconium in it. Very active. We want to make sure that they're not hypoactive or absent. Typically, when you're assessing a baby in postpartum, they're not going to have a cord like this. They're going to have it clamped. If it's a pretty new baby, you can still see on the end of the clamp the two arteries and one vein. But if not, if you can't, if it's already dried, then you can go into the chart and assess whether the baby was born with a 3-vessel cord, which is normal. We want 2 arteries and 1 vein. But don't feel like if you can't see that during your assessment, I mean, the baby, once it dries, you really can't tell.
How do I take care of the cord?
So what you want to do when you're assessing, you want to make sure that there's no drainage around the umbilical cord, that the clamp is secure. You want to educate your parents that they don't really have to do a lot with the cord. They don't have to put alcohol on it or anything. They just keep it clean and dry. And they want to make sure they don't put the baby in a submersion bath until the cord falls off, because that can cause an infection.
What would be signs of infection?
So if you were to be changing baby's diaper and you smell some, foul odor, or you see drainage, or it's weepy around it, that could be a sign of infection, and you need to call the pediatrician. When you are assessing a baby, if the baby has not had a first bowel movement, you want to assess the anus. And so what I do is I typically turn my baby over. They can be on their tummy, it's okay. And I kind of open up the little butt cheeks and check for the baby's anus to make sure. Now, if they haven't had a stool, you're going to say the anus appears patent. If they've had a stool, then you know it's patent, right? We know this kid's got a patent anus. And then you're also going to look in this area for what's called a sacral dimple, which can be an indication of spinal bifida. And sometimes they'll even have a little tuft of hair. This baby doesn't have that. If there is a dimple, you're going to want to open it and see if you can see the end. Sometimes if they can't see the end, they'll do an ultrasound on that area to make sure that there's no spinal bifida. You're going to check the baby's spine to make sure it's straight. You're also going to, at this time, listen to your posterior lung sounds. And everything sounds good. And so the back of the baby looks really good. We're going to bring this baby back over. We're going to change the diaper at this time. So we're changing the diaper. You want to make sure that a clean diaper. I always want to keep a clean diaper because they like to pee and poop. When you're looking at the genital area, you're going to inspect the urine. Sometimes it's difficult, especially if there's meconium in the diaper, but if you visualize the baby urinating, you want to see if it's clear. With a male baby, you're going to be looking at the penis to make sure that their urethral opening is at the tip, that they don't have hypospadias, which is where the urethral opening is the bottom. You want to check their testicles. You're going to feel for descended testes. You're going to see that their sac has rubra on it. Sometimes their testes aren't descended at birth, and that's okay. You just want to kind of sometimes they're up in the groin area for a little bit of time, and then they'll proceed down. But we just want to let the pediatrician know that we were not able to palpate testes. And then you're going to look for a hydrocele, which is where they have their scrotum is swollen. On a female baby, you're going to be looking that their labia is appropriate for gestational age. When you have a preterm baby, a lot of times their labia majora is separated, and they can have kind of a prominent clitoris. And you're going to check for any drainage, swelling. Because baby was in utero with mom, they can actually have a little bit of bleeding. It's a little bit of discharge. That's very normal. And you want to reassure your patient that that's a normal, it's because they have maternal hormones in their system at this time. And so everything looks normal with this guy and his genitalia. The baby has spontaneous movement. He's not favoring one side or to the other. Does not have a club foot, which would be where it was in or like out. I looked at the baby's palms. There's no palm, they have creases on their palms, but there's not a simian crease, which would be straight all the way across, which can be an indication of Down syndrome. I'm gonna check the baby's clavicles. No fracture. If you felt a fracture, it would feel like Rice Krispies under your fingers. We're also gonna do a hip click where you rotate the baby's hips like this to make sure they don't have a hip click, which they don't. He has all 5 fingers, all 5 toes. Again, he's normal, active. His skin is pink and dry. We did notice some vernix, which is that white cheesy substance that's on them. There's no meconium staining. He does not have any lanugo on the front of him, but when I turned him over, I did notice that, and that's that fine downy hair, which actually helps the vernix stick. He does have some peeling around here. He was a term baby, so that could be normal. I don't see any bruising. I didn't see any Mongolian spots, which is on the back of the sacral area. Sometimes they can have them on their extremities. I don't see any milia, which can be present on the nose. Almost looks like little white heads, but I don't see any of that. No erythema toxum, which is like the newborn rash. He doesn't have any of that. So we've looked at this baby. Everything seems normal. We're reassuring mom. Everything with baby looks great. You're doing a great job. Any questions for me, Mom?
How do I know that he's getting enough breast milk?
So that's a good question because sometimes we can't see what they're getting. So the rule of thumb with babies that are breastfeeding is day 1, they should have 1 wet diaper. Day 2 to continue on till you get to day 5. By day 5, they should be having 5 to 8 wet diapers a day, and that's how you know. Also, if your baby is crying unconsolably or becomes, a little jittery or can't maintain their temperature, it could be that they're getting a little dehydrated. And so that can also be an indication. But just keeping track of those diapers, and he's already had 2 wet diapers on day 2, so he's already ahead of the game. We're just in the morning.
Oh, good.
All right, and then just go ahead and wrap the baby up and give him back to mom.